بسم الله الرحمن الرحيم. السلام عليكم جميعا. Good evening everybody. Now we are going for mock 2 pathology. Okay.
Okay, hello, good evening, everyone. Dr. Tedros is not here, right? So we can take Dr. Sarouj from the spare list. Dr. Sarouj or Dr. Abdulrahman.
يا ابني ما هكسر فيكم واجبسكم، ايه المشكله؟ هكسرك واجبسك من عظمك، ايه المشكله؟ قال يكسر فيك. ماشي.
Dr. Abdulrahman, yes.
Yes, Dr. Maria. Good evening. Dr. Salah,
Good
good evening.
evening, how are you?
I'm okay. How are you?
How are you, Dr. Manam?
Hello, doctor.
Dr. Manam, can you please raise your voice so I can hear you properly?
تمام كده دكتور؟
تمام زي تمام. Okay, we will start the first question with you, Dr. Manam, then the second question with Dr. Abdulrahman, and go on. It's an easy and a very short station, to be honest. Okay. The Stanford station is a middle-aged diabetic Chinese male with an ulcer in the nasopharynx. He was on recent chemo and radiotherapy. First question for Dr. Manam is, what are the risk factors for nasopharyngeal cancer?
Okay, the risk factors: first, gender, twice male as female, ethnicity and race, most common in China, Hong Kong, Vietnam, Singapore, Philippines, and Malaysia. Fairly common in Northwest Canada and Greenland. And also regarding the diet, consumption of salted fish, and infection like Epstein-Barr virus, and the genetic factors, and family history, tobacco and alcohol use.
Okay, great answer. You don't have to mention all the countries though, because you don't want to waste your time. Just a couple of examples is more than enough, but perfect answer.
Okay.
Next question, Dr. Abdulrahman, can you define carcinoma?
A type of cancer that develops epithelium.
Okay, next question. What is your differential diagnosis for a swelling in the nasopharyngeal region?
Anna, I'm
Dr. Manam.
Okay, obstruction like adenoid hypertrophy, trauma like hematoma, infection like abscess, and tumor, benign angiofibroma, and malignant lymphoma, and rhabdomyosarcoma.
Okay, perfect. Okay, what other non-epithelial tumors can be here, Dr. Abdulrahman?
Lymphoma and rhabdomyosarcoma. Also angiomyofibroма.
Okay, also the question for you, Dr. Abdulrahman, if there is a palpable lymph node, how are you going to do assessment for it?
Tissue biopsy like needle aspiration, true cut biopsy, and excisional biopsy.
Okay. Next question. What is cytology versus histology?
Cytology look at the cells only, while histology look at the cell within the local tissue architecture.
Okay. Next question. What is the scale of radiation dose?
Colibri kilogram, the exposure and sulfur equivalent to exposure.
I'm asking about the dose, radiation dose only.
Gray.
Yes, perfect. Next question. If swab grow hyphae, what do you think this is?
Fungal infection.
Okay. What is the pattern of spread of nasopharyngeal cancer?
Lymphatic spread and also local spread.
Okay, can you tell me also the pattern of the local spread?
Okay, anterior nasal cavity and orbit infection. Also superior cavernous sinus and sphenoid sinuses, lateral parapharyngeal spaces and middle ear, inferiorly oropharynx and C1 vertebrae, posteriorly clevis and clevis and posterior middle posterior cranial fossa.
Okay, clevis and the base of the skull. Okay.
Yeah.
All right. Next question. What is the mechanism of radiotherapy? Dr. Manal?
Ionizing radiation works by damaging the DNA of the cancerous tissue, which lead to cellular damage.
Okay. Next question. What are the risk factors in this patient in particular for oral candidiasis?
Being diabetic and also radiation and chemotherapy.
Okay, perfect. Okay, this is the last question I have. It's a short station. Thank you very much for both of you.
You are,
Dr.
yeah.
Salah, do you have any extra questions?
No, this
Okay.
station was one of the new stations and is going exactly by this way. We have no updates for it. Regarding of the question of cytology and histology, I shared the file for you. Let us start by it. خلينا نخلصه مريء الأول الملف ده because it will come in many discussion.
Yeah, sure, of course, Dr. Salah. While we're discussing this, I hope that the people for the next station raise their hands so we would be ready and we don't waste time.
Okay, this is the file regarding of tissue diagnosis. I think this file in already with you. Already you have this file. Okay, difference between cytology and histology. The key difference is the histology looks at the cells within the local tissue architecture, while cytology looks for the cells only.
Dr. Salah, the screen is not clear.
No, it's clear.
Wala.
عندك انت.
Okay.
Regarding of histological, what you will see in cytology and histology, it's written down. It's written down. Okay. يعني ask it before what you will see in the cells about cytology and histology. It's written down. يعني ask it only once. What is the cytological features of malignancy? This question asked in many stations, any station of pregnancy. This question for sure is they are asking it. So you have cytological features and pathological features. Cytology and histology. Cytology and histology. The features which indicate malignancy in cytology: increased number of mitotic figures, abnormal mitosis, hyperchromatism, polymorphism, increased nuclear to cytoplasmic ratio. This according to cytology. Histology, invasion of the basement membrane mainly, plus loss of the normal tissue architecture. This is the most common things, plus some features like neovascularization, necrosis, hemorrhage can be seen. Advantage, disadvantage between both of them, I think discussed many times and should be by this way. The question asked before, Dr. Maria, I think you answered this question before about why cytology
Deemed inconclusive.
Yes, answer for them this question.
Okay. هو أنا مش معايا البتاع دلوقتي بس.
Because sample may be inadequate, lack of differentiation, and
yeah. Number one is the inadequate sample. Number two, when the cells is masked by inflammatory cells or blood cells. Okay, missed labeling. Okay, and poor technique.
I want to remember mislabeled.
Labeling, yes.
This also should be added. Okay. This question asked by the way, and they are not satisfied except by this answer. Okay. اوكي يلا مريم next station.
Okay. Next station, we will have 3 people. We have Dr. Adnan.
Hello, good evening.
Hello, good evening.
Hmm.
Dr. Muhammad Fadl. And Dr. Hussein.
Hi.
Hello.
Hello.
Okay, so we will start with the sequence of Dr. Adnan, then Dr. Muhammad, then Dr. Hussein. Is this okay with you guys?
Okay.
Okay.
Okay. So the Stanford station is a 56-year-old lady who has a bicuspid aortic valve, is admitted for laparotomy. Okay. First question for Dr. Adnan. Why is bicuspid aortic valve susceptible to infective endocarditis?
Because in bicuspid aortic, there is a risk, increased risk of stenosis and stasis of blood.
Okay. Second question. What is the pathogenesis of infective endocarditis from bicuspid valve? Dr. Muhammad Fadl. Dr. Muhammad? Okay, Dr. Hussein.
So here pathogenesis, it's about when the flow of the blood during along the aortic valve turbid, this will cause that making some vegetation, and it's a media for progressive for the bacteria. So this infection endocarditis will be happened.
Okay, so when the bicuspid valve is narrowed, there will be stasis, as you mentioned, which will increase the chance for the bacterial colonization on the damaged tissue. With recurrent attacks of inflammation, there is progressive fibrosis, narrowing, and stiffening of the valve later on. Okay?
Okay.
Great answer. Next question. What is the investigation of choice to identify vegetations in infective endocarditis? Dr. Muhammad, are you here? I don't know, he's unmuted, but he's not answering, or we are not hearing him. So Dr. Adnan, you can go ahead until he answers.
2D echo.
2D echo, that's true. Next question, also for you. What are the things that we are looking for in a 2D echo?
First thing, look for valvular regurgitation, looking for the leaflet prolapse, thickening, and nodules, chordal elongation or rupture, annular dilatation, pericardial fusion, ventricular dilatation and dysfunction, and the increased echogenicity of subvalvular apertures.
Okay. Next question, what are the causes of sudden death in patients with aortic stenosis?
Sudden death of, and it should be due to MI or aortic dissection, rupture for aortic dissection.
Okay. Next
so
question.
Here I want to ask something. Can I talk or explain why this patient has MI, or just mention MI?
No, just mention MI and aortic dissection, more than enough. If he wants any more explanation, he will ask you how or whatever, but they don't usually ask.
Yeah, sorry. You know, you are discussing with whom now?
What؟
نعم.
انت عارفه بتتناقش معاهم مين؟ عدنان مصرات واحمد فضل، تعرفيهم؟ The first
لا
time
ما
for
تقابلناش قبل كده.
these people, they are amazing. These
I
people, they,
can see.
you know. So not accepted any mistake or any short answer from them. I want complete answer, and they will do that. Yeah.
Inshallah. Thank you, Doctor.
Okay. Dr. Muhammad, are you here? You asked me to unmute you, and I did unmute you, so I don't know what the problem is. Okay, Dr. Adnan, can you tell me the clinical picture for aortic stenosis?
Clinical picture, according to the degree, it will be mild, moderate, or severe. In mild cases, it will be asymptomatic. Mild, moderate, asymptomatic. In moderate, severe, I think patient will become with angina, syncope, and dyspnea, orthopnea, lower limb edema. In severe cases, it will lead to sudden death.
Okay, and also there would be signs of complications like pericarditis and MI as well. Okay, next question. What is the pathophysiology of aortic stenosis? Or, in other words, how does aortic stenosis lead to death in explaining?
Okay, in aortic stenosis, there will be decrease in cardiac output, which one will decrease in the filling in the coronaries, which makes that the patient will get to MI. It would be sudden of death. Also, because aortic dissection, dissected flap, which may rupture, which cause severe hemorrhage, hypovolemia, death.
Okay, this is the cause for the causes that lead to death. What about the pathophysiology of the aortic stenosis?
Cardiac output, decrease for
No,
coronary filling.
I mean how, how it starts. So the aortic valve progress from sclerosis to stenosis, and this will cause the left ventricles to encounter chronic resistance, which will increase the systolic ejection, which is increase in the afterload, leading to the thickening of the left ventricular wall, which will cause hypertrophy.
Okay.
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 And then you continue. The effect of a high left ventricular afterload will include decrease in the left ventricular myocardial elasticity, and this will cause the coronary blood flow and decrease in the coronary blood flow and increase in the myocardial workload. So the oxygen consumption, and eventually it would cause mortality.
Okay.
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 The answer was shared by Dr. Suzanne and Dr. Salah before, right? Okay, next question. What are the surgical options to treat aortic stenosis?
Mechanical valve, a tissue valve, and Ross procedure, and the TAVR transcatheter aortic valve replacement.
Okay. Can you tell me the difference between the mechanical and the tissue valve?
Okay.
Me.
Mechanical? Me or?
Yes, Dr. Hussein.
For mechanical valve have longer duration, and it needs to take Marivan to prevent thromboembolism. Also, there's an ability for hemorrhage for 200% and easy to be insert. About the tissue valve, it's less duration as may be degenerative after 5 years, not need for Marivan, less liability for hemorrhage, and difficult to be inserted.
You will not need warfarin at all?
At tissue valve, we need about Marivan at the first 3 months only.
Yes, exactly.
And also we can give Asposide Plavix instead of Marivan.
All right. Okay, next question. What is the non-surgical option for valve replacement?
We have TAVI and TAVR procedure, transcatheter aortic valve replacement.
Okay. Also the question for you. If the metallic valve replacement was done and the patient developed infective endocarditis, what will be your next step and explain why?
We'll remove the valve because it will be a septic foci and it will be dehiscent.
Anything else?
Yes. I don't know.
It will be very, very difficult to treat with antibiotic because there is no blood supply and
Yes.
because of the formation of a biofilm around it. So there will be no option other than removing it. Okay, what is the commonest bacteria cause infection of prosthetic valve?
Common bacteria, it will be Streptococcus viridans and coagulase negative
Prosthetic
bacteria. For prosthetic, Streptococcus epidermis. Streptococcus
Okay,
epidermis.
it's actually staph.
Okay, staph. Okay, I'm sorry.
Staphylococcus epidermidis.
Okay.
Oh, wait. What about Staphylococcus aureus? Can be or not?
Since Staphylococcus aureus, it's most common with skin infections or surgical site infections.
So with valve,
It may happen.
valve.
It can be.
It can be, but not in prosthetic valve.
Sure.
I
I will
didn't
share.
see that Staph aureus before prosthetic valve.
طيب continue.
Okay, next question. If you find the microscopic branching hyphae on the removal of the valve, what is the cause and the types?
It's a fungal infection, like Candida, Aspergillus, Microsporum, and Epidermophyton.
Okay. A patient, let me see. A patient with mechanical valve replacement after a while start complaining of arm weakness. What do you think the cause for that?
I think that it may cause thromboembolism, which cause some cerebral stroke, which cause weakness, arm weakness.
Okay, perfect. Next question. Do you prescribe anticoagulants post-valve replacement?
Yes.
Which one is most common?
Warfarin.
Next question. The mode of action of warfarin?
It stops vitamin K intrinsic factors, intrinsic coagulative factors, which factors about 10, 9, 7, and 3.
Are you sure?
And
Dr.
2
Adnan?
vitamin.
Yeah.
And it's to be vitamin K absorbed. Like?
I'm sorry, again, I didn't hear the last part.
And it's treated by giving vitamin K, fresh frozen plasma.
No, I'm just asking about the mode of action. Okay. So the mechanism of action is it's a vitamin K antagonist that inhibits the clotting factors, which are 1972. Okay. Which pathway is not affected by warfarin?
Intrinsic pathway.
Okay. Also the question for you, can you tell me the common pathway of clot formation?
Common pathway is activation of the prothrombin to thrombin, then thrombin activate the fibrinogen to fibrin.
Next question, can you define thrombus?
Thrombus, it's a constitutions formed by blood constitutions due to blood flow.
Again, please.
It's about it's format of blood constitution. I don't remember the definition. Sorry.
Okay, Dr. Adnan, do you know the definition?
A solid material formed from blood constituents in flowing blood.
Okay, it's in constant blood, not in flowing blood. It remains in the same position. The clot is the one that
Yeah.
moves. Okay, so the thrombus is defined as a product of the coagulation pathway formed by the constituent of the blood, but remains in its same position. Okay. What type of complication happen to non-displaced thrombus?
It can become infected and lead to inflammation.
Okay, perfect. Next question. What test you will do if you suspect that the thrombus is infected?
Investigate. CRP and ESR and CBC
Yes.
for TLC count.
Okay. Anything else?
That's for blood investigations.
Just one
And
more.
maybe
Or
I will take the CBC, CRP, ESR, and maybe take blood cultures to detect
yes,
the
exactly.
organism.
Blood culture. Exactly. That's what I'm waiting for. Okay, next question. What is CRB?
CRP is acute phase reactant, which is produced by the liver and used to monitor disease progression.
Okay. What are you looking for in the blood culture?
Look for gram positive, gram negatives, anaerobics, and also the Hackett group.
Yes. Next question. What is the type of endocarditis that occur with adenocarcinoma?
Lip and sac.
Yes. What is the antibiotic guidelines that what's the antibiotic guidelines in patient with aortic stenosis?
We have according there's the NICE guidelines and SIGN guidelines.
And what do they state?
NICE guidelines state that it's not necessary to give antibiotics before dental, only in major procedure, major surgeries, and SIGN guidelines, no need for antibiotics.
Okay. Major procedures and highly infectious ones.
Highly infectious.
Okay, that's the last question I have. I know it's a very long station,
Back.
but great job.
Go back.
Thank you very much.
What you will look for in blood culture? What is the answer? Question.
Gram positive, negatives, anaerobics, and the Hackett group.
He's waiting Hackett, by the way. Not gram positive or anaerobes. He's waiting Hackett. What is Hackett you are looking for?
Hemophilus species, Agricatibacter, Cardiobacterium, Echinella, and Kingella.
Okay. By the way, the discussion of this station plus the file I shared for you exactly send from one who has this station before. Okay. So some of candidates, they told me, to Salah, they asked me how to do blood culture. No, they didn't ask this question, by the way. The feedback came for me about blood culture, about what you will look for. What you will look for. Then they will ask here about fish. Fish will be discussed, inshallah. This is the end of this station. They will ask about fish. So station is going exactly like Dr. Maria discussed now. Also, they have question about the asked before. نسيتيها يا مريم. أشوف this is asked in Cairo. أشوف nodules. What is أشوف nodules?
أشوف nodules granulomatous inflammations consisting of central degenerated central zone of degenerated extracellular material that infiltrated by lymphocyte plasma cells and anti-Schoof cells.
Excellent. They asking about the histopathology of each of nodules, not to tell granular information only. So you should tell consistent of what? Central zone, which will be infiltrated by lymphocytes plasma cells, and the central area of necrosis beside the area of collection of mononuclear cells. Wait, antibiotic, yes. Okay. About limb and sac endocarditis, this is a type of sterile non-bacterial. This can be associated with adenocarcinoma. Okay. Other question, what is aortic sclerosis?
It's a valve disease without significant gradient across the valve.
Can be progressed to stenosis. Coagulation cascade, this was my station, by the way, in Al Bahrain. But they didn't ask me all these questions. I remember they asked me about the coagulation cascade. Intrinsic, could you explain intrinsic pathway in simple words? Extrinsic pathway started by tissue factor, and then on factor 7, this will activate factor 10. Then factor 10 will activate prothrombin to thrombin, and the thrombin will activate fibrin and fibrin clot. While intrinsic pathway started from 12, 11, 9, 8, then this will activate. We'll go for the pathway which factor 10. They asked this question. تمام كده؟ طيب. Regarding of the last questions asked before, I didn't discuss this before, the checklist of the one paper only of checklist for this station. As written with me, I have only 2 or 3 questions. Regarding of antibiotic prophylaxis against endocarditis in uncomplicated surgery should no longer be given. Specific antibiotic prophylaxis is still required. So, the candidate should be aware of both current practice and recent guidelines from either NICE or SIGN, the following summary like we discussed now. Like you discussed about NICE guidelines is what described as not recommended to give antibiotic, and also SIGN guideline does not specify cover of endocarditis and refers to the guidance of Society for Antimicrobial Chemotherapy. This what is abbreviation of SIGN. Anyhow, by simple words, you have 2 guidelines, both of them recommending antibiotic. Look at the ECG. Calculate heart rate will be discussed later. What cardiac condition does this ECG will discuss later also. I think that's all about this station. We covered all the. Sorry, I forget another about hand signs for infective endocarditis. What is hand signs you can find?
Osler nodules, splinter hemorrhage, and GLWay lesions.
And the pathophysiology behind everyone.
Osler nodules, it's about immunocomplexes, which is raised and painful. GLWay lesions, it's about microabscesses of the bacteria, which is in palm of the hands mostly. Splinter hemorrhage is in the nails.
Excellent. Due to tiny blood clots under the nails. Because this asked once before. Okay. I think covered all the questions. This session will come, so you covered all the questions with updates. تمام كده؟
Okay.
Great.
Okay, we will move on to the next station. We have Dr. Nurhan and Dr. Abdulrahman.
Thanks for all papers shared by Linda. Look for these papers.
Hello, Dr. Salah. Hello, Dr. Maria.
Hello.
Hello, sir. Hello.
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 معلش, who's talking?
I'm Dr. Abdurrahman, and Dr.
How are
Nurhan is
you?
sharing the same mic so that we will not make an echo.
Okay, that's great.
Okay.
Okay, we will start with you. One question for you, one question for her, right?
Okay.
Okay, great. Your station is a 58-year-old lady with sickle cell disease, fell down and sustained an injury to the parietal area. A CT scan was done showing a space-occupying lesion. Okay. First question. What is sickle cell disease?
So sickle cell disease is an autosomal recessive disease caused by mutation done to the beta globulin that promotes polymerization of deoxygenated hemoglobin, which leads to red cell distortion, hemolytic anemia, and microvascular obstruction. Whereas hemoglobin S is produced by the substitution of valine instead of glutamic acid at the 6 amino acid residue of beta globin.
Okay, perfect. Already you answered this question. How is it inherited? It's an autosomal recessive. Okay. Next question. What is the surgical concerns in a patient with sickle cell disease?
Anemia from wound healing, avascular bone necrosis, osteomyelitis. The patient may develop gallbladder stones or otosplenectomy, and also pulmonary hypertension and heart failure.
صوتك مش واضح، قرب المايك وعيد الإجابة تاني.
علي صوتك بس.
علي صوتك.
Okay, anemia from wound healing, pulmonary hypertension and heart failure, avascular bone necrosis, osteomyelitis, and lastly gallbladder stone and otosplenectomy.
Okay, next question. Why patient will suffer of bone pain?
Due to vaso-occlusive crisis.
Okay, can you explain more?
Should I elaborate? Okay,
yes,
vaso-occlusive crisis is triggered by infection, dehydration, and acidosis, which causes painful bone crisis, as in hand-foot syndrome. It can cause also acute chest syndrome and stroke. Okay.
Okay. Next question. Why do you think this patient is immunocompromised?
Due to otosplenectomy.
Okay. Can you elaborate more, please?
When the patient has multiple vaso-occlusive crisis, part of the spleen is autodigested, and at the end it will lead to otosplenectomy. So the patient will be susceptible to encapsulated bacteria. Like Streptococcus pneumoniae and Neisseria meningitidis and Haemophilus influenza.
Perfect. Next question. What do you think the space-occupying lesion is?
I think this is mostly a brain tumor.
Okay.
Since the lady is 58 years old, I think it could be a glioblastoma multiforme.
Okay. What's the most common primary brain tumor of parenchymal origin?
Glioblastoma multiforme and medulloblastoma.
Okay. What are the other tumors that you know?
There are some low-grade tumors such as meningiomas, neurofibroma, pituitary tumors, acoustic neuroma, and craniopharyngiomas. And secondaries.
Secondaries, exactly. Okay, next question. What is the natural history of brain tumor if left untreated?
It's a space-occupying lesion, therefore.
Can you just get closer to the mic a little bit?
It's a space-occupying
أنا عارفة دكتور
lesion.
عبد الرحمن واخد المايك وسايبه منك.
لا والله بديها سماعة، والله بديها سماعة، بديها فردة.
Okay, just get closer to the mic a little bit.
ده الاثنين يا باشا، مش واحدة، ده الاثنين.
It's a space-occupying lesion. Can you hear me properly right now?
Yes, what's the natural history of brain tumor if left untreated?
It will cause to death at the end because it's a space-occupying lesion. It will increase the intracranial pressure, therefore herniation and of the important centers as the respiratory center, leading to death.
Okay. Next question. A biopsy was done and it shows some squamous cell. What do you think?
I think it could be a metastatic squamous cell carcinoma.
Okay, can you tell me the primary sites of the squamous cell carcinoma you would suspect?
It could be the skin, lung, esophagus, nasopharynx, maybe the cervix.
Okay, perfect. Next question. Post-operative craniotomy was done and the wound got infected. What is the common organism?
Staph aureus.
Okay. Next question. A fluid from the wound show glucose 3.2 millimole. What does this mean?
Cerebrospinal fluid leakage.
Perfect. Last question. What is the function of spleen?
Spleen is important for the extramedullary hemophilesis, for immunity and defense mechanism of the body, for removal of abnormal RBCs.
For infection.
And synthesis of IG.
And synthesis, okay.
Okay. Thank you very much. That was the last question I have. Dr. Salah, do you have any extra question?
No, regarding Mrcs station came in last May in UK, and all the questions like our book, nothing more. But I forget one question in infective endocarditis. I forget question in infective endocarditis. I remember it now. So in patient with aortic stenosis, they will ask, what do you think is the cause? He's waiting a congenital bicuspid aortic valve plus many things. Then we'll ask you about hyphae. The question of hyphae, Dr. Maria. What will be the cause if you will find, because we'll ask you what is the histopathology finding of the removed valve. You can find a branching hyphae. So we'll ask you what is the cause. Many they told the fungal infection. He's not accepting the fungal infection, by the way, candidiasis or something like that. He's waiting aspergillosis. So
We
at this
answered it, Dr. Salah.
انا عارف بتاكد عليه بس تاني.
Yeah.
Other than this, or everything discussed in the post station like came on last May on UK. الله ينور عبد الرحمن، الله ينور روحان، ما شاء الله.
حبيبي يا باشا.
Yeah. Allah knows.
Thank you.
Okay, moving on to the next station, we have Dr. Mark and Dr. Barumade.
Hello.
Hello.
Yes.
How are you?
Not too bad. And you?
Not too bad as well.
Good.
Okay. Yeah, a male patient present with the left knee swelling and redness with history of tibial fracture and internal fixation couple of years ago. Okay.
Yeah.
We will start with Dr. Brumo, first question for her, and then the second question for Dr. Mark and go on. Okay.
Okay.
Okay. The first question, what is the bedside investigation that you would like to perform for the knee swelling?
The knee swelling, aspiration, and culture sensitivity.
So it's aspiration. That's correct.
Yes.
Okay. Next question, Dr. Mark. What are the things that you look for in the aspirate fluid?
Look at the color, look at viscosity, I look out for some crystals as well, and sometimes odor. The test will be gram stain, cytology, and culture sensitivity.
Anything else?
Is it in terms of what I look for or the test?
The test.
The test is gram stain, cytology, culture sensitivity, and probably do biochemistry on it.
Crystals.
Crystals.
Okay. So you are given a pathology report showing proteins, cocci, and polymorphic nuclear lymphocytes. What would be your diagnosis?
Acute osteomyelitis.
Acute?
Looks like chronic.
Chronic osteomyelitis.
Yes, of course, it's chronic osteomyelitis. Also, the question for you, what do you think the cause for this chronic osteomyelitis?
Due to the implantation.
The what? I'm sorry?
Implantation.
Yes, the implant for the internal fixation.
Yes.
Next question, Dr. Merck, what is the common organism?
Mostly Staphylococcus aureus.
Okay, also the question for you, how is pus formed or what is the pathogenesis for pus?
It's mostly microbial invasion and then inflammation, followed by accumulation of neutrophils and exudate formation.
Okay. Next question, why pus will burst through the bone?
Is it for me? Or
For Dr. Burma, yes.
Yes. Due to inflammatory process, there is increased intraosseous pressure due to increased osmolarity, which occurs due to tissue breakdown. And due to this increased intraosseous pressure, there is formation of a large cloacal opening through the involucrum. So the pus can escape through this opening through the involucrum surrounding tissue and skin.
Perfect. Next question, Dr. Merck. Why do you think squamous cell carcinoma would develop and what's the sequence of events that leads to it?
it developed because of chronic irritation. The sequence is mostly because of the chronic inflammation coupled with the irritation would cause hyperplasia and then dysplasia, which eventually lead to carcinoma.
It's actually metaplasia than dysplasia, which is carcinoma in situ, then carcinoma eventually.
Okay.
Okay, next question. What is the name of protein deposition in osteomyelitis?
Amyloid AA.
Okay. What is the specific pathological name for pus around screw and implants?
Biofilm.
Perfect. Next question. What is the definition of sequestrum and involucrum?
Sequestrum is a dead bone that has become separated during the necrotic process from the surrounding normal bone. It's a complications of osteomyelitis. And involucrum is a reactive oven or lamellar bone formation, forming a shell of living tissue around the sequestrum.
Okay. Next question, what's the type of crystals in gout and pseudogout?
So in gout, we have the urate, monosodium, and in pseudogout, we have the calcium pyrophosphate. In terms of the birefringent, pseudogout is positive. For gout, it's negative. And then shape-wise, I think gout is mostly spindle, and then pseudogout is a bit of cuboidal.
Pseudogout is rhomboidal, yes, and the gout is needle shape or spindle shape. Okay, we already said this question. Let's repeat it. Okay, next question. Why amyloid cannot be removed from the body?
Because amyloid is a stable and larger protein, and our body does not have enzyme for degradation of the amyloid. That is why it cannot be removed from the body.
Okay. The types of amyloid deposition?
We have amyloid AA, amyloid AL, and I think we have beta amyloid as well.
Yeah. Okay, that's the last question I have. Thank you very much.
Thank you too.
Dr. Salah, I think you might have extra questions.
كيف كده يعني ولا لا؟
أكيد هيبقى عندك extra questions.
انا لازم اخبي حاجه، ما انا قايل لسوزان اخر مره. خدي بالك لما انا بتكلم قدام سوزان بقول لهم ماريا وبقول اللي معانا في الجروب ماريا وسوزان هيعملوا الكورس لوحدهم. عارفه المفاجاه هم قالوا ايه؟ هنروح مع ماريا وسوزان. ده الاصل. انتوا بتهزروا؟ انا معلش مخبي شويه حاجات عن ماريا كده. والله قالوا كده. والدكتوره وداد متزعمه من حركه التمرد ديت. قلت لهم ماشي مش مشكله، كده هنقضيها بقى ايه. انا عارف شو هيقضيها ازاي، انا عارف مش عايز هم عارفين. طيب الاول قبل ما تفصل بس وتروح تدي كورس بس لوحدها، ماريا who advised you for this station when it came in your exam؟ قوليها كده بالله عليكي كده وسمعيني.
It was you. I
أيوة.
called you the night of the exam and I asked you that all the candidates who went before me, the examiner did not accept any answers for the diagnosis. And you told me just say chronic osteomyelitis, and he was actually very happy with my answer.
تمام كده.
Because everyone went for the exam and said osteomyelitis, and he was not happy with just osteomyelitis. He was waiting for chronic osteomyelitis.
بيقول لك كان هينط من على الكرسي، انت قلت لي كده كان هينط من على الكرسي ما كانش مصدق. صح؟ لا يعني قبل بس بايه، قبل ما تتمرضوا، بس قبل ما تتمرضوا. طيب
طلعش دكتور صح.
ماشي. We have some updates in this station. This station came in Lahore. This station came in Lahore in November and came also in Dubai. ايوه خليك فاكر يا سعيد، خلينا فاكرين المقطع ده في اي دقيقه عشان انا مسجله لها اهوت، اول ما كده اطلعه لها. ما انا مسجل للاخ التعبان في دماغه مسجله، بس مش عايز اطلع له مش عايز اطلع له والله، مسجله والله مسجله وانا بتناقش معاه كمان، بس يلا المهم. This station came in Lahore and came also in Dubai. Updates about what you will look for in aspirate. Dr. Maria discussed about it. This came in Cairo last time in Cairo. When this station came in Cairo, I think on March. I think it came in Cairo last March. So ask it about what you will look for in aspirate: viscosity, color, turbidity, white blood cells, polymorphic nucleus, and crystals. In Dubai, they told me about one question: what is the intraoperative measures? What is the intraoperative measures to prevent osteomyelitis? يعني patient you are doing any fixation. So what is the intraoperative measure to avoid this? Number one, antibiotics. Number two, good preparation to the patient. Number three, avoid long starvation hours. Number four, aseptic techniques for sure. And he's waiting laminar flow in the theater. Okay.
Yeah.
Why there is increasing chance of osteomyelitis in rheumatoid arthritis patient? Why there is a chance for increased osteomyelitis in this patient? Because immunocompromised, and this and may be taking any immunosuppressive drugs and corticosteroids. What is the biofilm? Pass around the implant, like we discussed. Okay. In UK, in this station came in UK, I think February. It came with abscess. It came with abscess, osteomyelitis and abscess. And he went for abscess, like we discussed yesterday or before yesterday. So most likely pathogen organisms in abscess, content of the abscess, definition of abscess, fate of abscess. After removing implant, what you will do? Debridement. I shared in the group site. I shared this in the group. I shared in the group. هتعمل ايه في السيتر يا ابني عشان تمنع لامينر فلو؟ اوكي خلينا بس نكمل بس الحته الثانيه. Why massive debridement? He's asking when you are doing fixation how to do this, what you will do to prevent osteomyelitis to be developed. Not massive debridement. This is the next question. So you will give antibiotic, good preparation, antiseptic technique, avoid long starvation and others. Okay. انت دخلت سؤالين في بعض. What you will do in OR. So next question: after removing the implant, what you will do? Good debridement for the patient, taking culture, taking culture swab for taking a swab from the pus for culture insensitivity. So the other questions asked was osteomyelitis, definition of abscess, content of the abscess, fate of abscess, organisms of abscess, and what you will remove, what you will do after removing the implant. These are the other questions. تمام كده؟ اعتقد كده خلصنا كده يا مريم كلهم.
Yeah.
طيب يلا next.
Okay, next we have Dr. Farheen and Dr. Mustafa.
Hello.
Hello, how are you?
Yeah, I'm fine. Thank you. How are you?
I'm good, thank you.
Hello, Assalamu alaikum.
Alaikum salam. Thank you very much for Dr. Bromade and Dr. Mark. You did a great job. Thank you, guys.
Thank you too.
Okay.
You did great, by the way.
We will start with Dr. Mustafa, then Dr. Farheen, and then we switch. Okay.
All right.
Okay, great. Okay, so an old lady complaining of a lesion in her face, and you are given the picture for this lesion, and you're asked to describe the physical findings.
So it is a purple or pearly papule with central ulcer with granulation tissue in the base. The edges is inverted with surrounding telangiectasia.
Okay, next question. What would be your differential diagnosis?
I think there could be basal cell carcinoma, squamous cell carcinoma, tuberculosis, actinic keratosis, seborrheic keratosis, and verruca vulgaris.
Okay, so you are given a histology report. Okay, what are the things that you look for in the histology report?
The size, the margins, the depths, and the lymph node invasion.
No. If there is unclear margin, what would you do next?
I will plan for the re-excision up to safety margin, and I'll go for frozen section with most technique.
Okay. If there is a lymph node involvement, what you will do about this?
Fine needle aspiration biopsy for the lymph node or excisional biopsy.
Yes, excisional biopsy. I would start with excisional biopsy or then fine needle.
Okay.
Okay. What is frozen section?
It's a technique to examine fresh tissue intraoperatively. It's by snap freezing the tissue, then section cutting, and examine the tissues under microscope after staining and assess the tissues intraoperatively.
Yeah. Next question. How do malignant cells reach to the lymph nodes?
By permeation and embolization.
Okay, what else?
Tumor cells induce growth factors that initiate lymph angiogenesis in the tumor and drain in the sentinel lymph node.
Okay. Next question. A skin graft was done and the patient had a graft failure subsequently. Okay, what is the possible causes for graft failure?
Own infection.
I'm sorry, again?
Owned infection. Or infection, owned infection.
Yeah, infection and what else?
Infection and immunocompromisation.
Hematoma, maybe.
Yes.
Wound.
Hematoma and wound infection. Okay.
Yes, thank you.
Okay, next question. What is the common organism for wound infection?
Staphylococcus aureus, streptococcus, enterococcus.
No. What will you do to diagnose this infection?
I will collect the sample from the infection site and send for culture sensitivity test.
Okay. Next question. What is MRSA?
Methicillin resistant Staphylococcus aureus.
Next question. What will you do if the swab turn out to be MRSA positive?
I will inform the infection control team and take advice consecutively with the microbiologist. If I want to treat the patient in outpatient department, I will advise either clindamycin, amoxicillin,
No. What's
tetracycline.
This is your patient. What's the first thing that you will do after you mentioned with the microbiology or the communicable disease or what's the first thing that you will do?
I will counsel the patient about the report and try to figure out how she
No.
got that infection.
No.
I'm
Dr.
sorry,
Mustafa, do you
ma'am.
know?
We can go for debridement for the wound first of all.
No.
The-
The first thing that you will do is isolate the patient.
okay.
Oh, all right. Thank
Okay.
you. Thank
So
you.
the first thing that we are going to do is isolate the patient, and then you can continue with your answer. You can go on.
All right, thank you. And if I want to treat the patient in inpatient department, I will prefer to use vancomycin first or clindamycin and rifampicin. If it's a resistant case, I can consider linezolid.
Okay. Who will you involve in the management?
So infection control team, microbiologist, surgeons, and the blast.
Okay. The patient developed later on axillary lymph node enlargement. A lymph node biopsy was taken, and large cells with bilobe nucleus with prominent eosinophilic inclusions like nuclei resembling an owl eye appearance was found. Like this. What is your diagnosis?
Seems like the Hodgkin's lymphoma. It's a typical finding, and I can see the Reed's Donovan cell here.
Next question, define carcinoma.
Cancer of the epithelial cell.
Perfect. What are the features of malignant cells?
And evidence of neoplasia, evidence of cytologically, what did it say, cytologically different types of cells, cellular disorientation, abnormal cellular structure.
Like what?
Like distorted nucleus.
Yes.
And the size and shape is not is like not
Increase in the nucleus
the nucleus
cytoplasmic
and
ratio.
cytoplasm ratio, exactly.
Yes, increase in the mitotic count. Okay, this is the last question I have. I think Dr. Salah just mentioned the features of the malignant cells at the beginning.
Yes.
Yes.
Only try to adjust your answers according to the file I shared it before. Okay, adjust your answer about features of malignant cells in histology. And if asking the question by this way, better to answer according to the histological appearance and according to cytological appearance. Yeah, divided by. It will be very nice, by the way. Okay. This question, the time not came, so just keep what you have now. Okay.
Okay.
Yeah. You are doing great.
Thank you.
Thank
you. Thank you. Thank you very
Thank you.
much.
Thank you both of you very much. Thank you. Okay, moving on to the next station. We have Dr. Haifa and Dr. Hiba.
Hello.
Hello.
How are you?
How are you?
Fine.
Okay.
هو لو ماريا وسوزان فصلوا يا هبه هتروح عند السودانيه ولا هتيجي معايا؟
هاجي معاكم
هي معايا.
ولا ما تيجي
لا هبه لا هبه معرفه قديمه عمرها ما تسيبني لا انا متاكد يعني.
اوكي.
احنا على فكره ما نعرفش نستغنى عن الاثنين دولت، يعني ماريا وسوزان مش عايز اقول لكم يعني دولت ما ينفعش نستغنى عنهم مطلقا. يعني لو جيتوا في وقت لقيتونا اختلفنا وهم سابوا الكورس يبقى احنا اللي غلطانين. خلاص كده من اولها اهوت. يلا.
ما نستغناش بصراحة والله.
بس انا هقتل لكم سوزان في يوم على فكره، يعني سوزان دي ممكن هتتقتل في يوم، انا يعني في يوم كده هتلاقوا جريمه بشعه يبقى اعرف من القاتل يعني. ماشي يلا.
Okay, yeah, the station have a lot of updates فدكتور صلاح يحضرها عشان أنا في حاجات كتير ما زودتهاش بصراحة.
دي ايه دي ايه
Guest.
طيب يلا.
Okay. All right. So as I remember, the stem of this station started with a patient who is having jaundice, right? And then the examiner first question was, what is jaundice? We will start with Dr. Ahiba or any one of you. It's okay.
Okay. It's a yellowish discoloration of the skin tissue fluids due to deposition of the bile pigment.
Okay. Next question. Why do you think a patient with GEST may present with jaundice?
It could be to liver metastasis.
I know, Dr. Haifa.
Okay.
This will be related to the position of the tumor or the location of the tumor. It may result in biliary obstruction if it's present around the ampulla of Vater.
Okay, what else?
Also could be secondary to liver involvement.
Secondary what?
To liver involvement.
Liver involvement?
Yes, can you hear me?
Yes, so liver metastasis. I think you have some sort of an echo. Okay, what else?
Secondary to imatinib's
yes, exactly.
treatment, which lead to increased liver enzyme.
Yes, so we have three reasons: the biliary obstruction around the ampulla of Vater, the liver metastasis, and secondary to the imatinib therapy. Okay. All right, next question. What is GEST?
It is gastrointestinal stromal tumor that involves the GIT, mainly the small intestine, and the stomach. Arise from interstitial cell Kajal.
Okay. Next question. How does it differ from gastric cancer?
So gastrointestinal stromal tumors, unlike most of the... Miss Maria, can you hear me well?
Yes, I can hear you.
Okay, so unlike most of gastrointestinal tumors, gastrointestinal stromal tumors arise from the connective tissue and they are sarcomas. Also, they arise from cells in the intestine, specialized cells called interstitial cells of Kajal, which are normally present in the a part of the nervous system of the intestine. Lymph node metastasis, unlike gastric carcinoma, is uncommon in gastrointestinal stromal tumors. Also, distant metastasis is associated commonly with the stromal tumors of the peritoneum, mesentery, liver, and omentum. And lastly, the gastrointestinal stromal tumor have a high tendency to seed. That's why intraperitoneal metastasis and even scar metastasis are known to occur.
Perfect. Okay, what is the clinical presentation of GEST?
About 60–70% will be presented with vague symptoms, such as nausea, vomiting, abdominal discomfort, and early satiety and weight loss. 30–40% will present with bleeding due to erosions of the tumor into the GIT lumen. Will present with hematemesis, melena, or anemia. And if it is in the esophagus, they may present with dysphagia, jaundice due to biliary obstruction around the ampulla of Vater, and intussusception if it is in the small intestine or small bowel.
Okay. Function of bile?
Emulsification of fat into micelles, providing a great surface area for the action of the enzyme lipase, pancreatic lipase.
Okay. How does bile salts help in the emulsification? It's the same answer, so it's okay. What is bilirubin conjugated to?
glucuronic acid by glucuronic transferase enzyme.
Okay. Can you tell me about the bilirubin metabolism?
Yes, conjugated bilirubin will go to the bile and then go out to the small intestine, where most of the bile salts are reabsorbed back into the anterior hepatic circulation. The conjugated bilirubin will not be reabsorbed back to the anterior hepatic circulation and will pass to the colon. In the colon, the conjugated bilirubin is disconjugated and metabolized by the colonic flora into the urobilinogen, where most of it is oxidized into the stercobilinogen, which gives the stool its characteristic brown color. However, some amount of urobilinogen is reabsorbed back into the anterior hepatic circulation, and then it is released again from the liver and goes back to the bloodstream to be processed by the kidney, giving it its yellow color.
Okay. Next question, how urobilinogen is formed?
It's formed by by conversion of the bilirubin in, by the gut flora.
Yes.
Some will be oxidized to stercobilinogen and excreted into the feces, and the rest of them will be metabolized, reabsorbed to portal circulation, and the remain will be excreted in the urine.
So how is it formed? Is simply by the effect of the bacterial flora. So it's okay. A mass has been found. How are you going to diagnose it?
Okay, so I can do a CT abdomen with contrast. I can also perform an upper endoscopy and endoscopic ultrasound. But the definitive diagnosis is with tissue biopsy for histopathology and immunohistochemistry, which there are specific antibodies to stain the CD117 molecule.
Okay,
Also,
next question. What is the CD117 and how to detect it?
It is proto-oncogene C kit. It's known as tyrosine protein kinase kit or stem mast cell growth factor receptor. It will be detected by immunohistochemistry.
Okay. What other cells that show CD117 to be positive?
mast cells.
Okay. And what would be your management plan?
According to the size of the tumor, if it is small, less than 2 centimeters, it will be on this a conservative management and surveillance endoscopy every 6 to 12 months. If it is symptomatic, we'll start with imatinib and resection.
What is the value of CD117 in the treatment?
A positive result for CD117 means that the KIT gene is overexpressed or amplified in this type of tumor, and it gives a clue or an impression that the tumor would be responsive for imatinib.
Okay. What is H. pylori and which part is usually affected?
Helicobacter pylori. It affects the antrum. Don't know what they want by.
The effect the antrum, yes. Is it gram negative, gram positive? What it is?
It's gram negative motile flagellum related. Yeah.
Okay, which cancer other than adenomas that H. pylori can cause?
This would be mucosal associated lymphoid tissue tumor.
Yes. What is the causes for vitamin B12 deficiency?
Lack of absorption of intrinsic factors. Could be due to alcoholism, hypothyroidism also.
Okay, but yeah, I think this is the last question I have. I will leave the rest for Dr. Salah. I think they asked also about ascites in the station.
A guest coming with obstructive jaundice and came by this way exactly in March in Cairo. And I get the feedback from people in Cairo exam غدا exactly like this way. Okay, but last exam they brought gastric carcinoma with guest. ما العلامه كانت 12 اهو I'm coming gastric carcinoma with guest and they have other new questions. انت معاك الجاستريك كارسوما النهارده ولا بكره؟
لا متهيألي بكرة.
طيب I will discuss the questions now because the combination came already between guest and the gastric carcinoma. By the way, this is exactly what came. But in Cairo, they brought gastric carcinoma plus some new questions. I forget to tell you yesterday about polycystic kidney disease. We have also new questions. I will tell the update of polycystic kidney disease at the end, inshallah. Now let us go for the notes group. So gastric carcinoma will be discussed tomorrow, but we will discuss the questions as how it came. Okay, from here. First question, what is the CDH1 gene and what is its function? And who will be screened? What other malignancy of stomach other than adenocarcinoma associated with CDH1? صعبة الأسئلة؟
Yes.
ده اللي جت في 12 بقى يا سعيد. Came last December. These are the questions. What is CDH1 gene, its function, and which patient you will do screen, and what other malignancies associated with it, why there is enlargement of lymph node draining area abscess. This is discussed about abscess. Okay, these are the questions here. So we will start from here. CDH and should be who should be tested for CDH1 mutation gene. For the questions here, this link is very important. I brought the answer from it. So the function of CDH1 gene provides instructions for making a protein called epithelial Catherine or Catherine protein. This protein found within the membrane which surrounds the epithelial cells, which are the cells that line the surface and the cavities of the body, such as inside of the eyelid and the mouth. Okay. Screening. You have very important guidelines or organization named International Gastric Cancer Linkage. They are doing a screening for whom? Whose patient you will go for a screening for CDH1 gene. So you should keep what is CDH and what is function, like I wrote for you, by very simple words, by the way. I brought from the link, some told I will do screening for a patient who has positive family history, not accepted. Exactly the three things you will do a screening for them for CDH1 gene. Number one, 2 or more cases of gastric cancer in first or second degree relatives, regardless the age, with at least one confirmed diffuse gastric carcinoma. You have two people of gastric carcinoma from the first or second degree relatives, whatever the age, and one of them diagnosed as diffuse gastric carcinoma. Okay, or a diffuse gastric carcinoma before age of 40 without a family history, Number 3, families who with diagnosis of both diffuse gastric cancer and lobar breast carcinoma, at least one before age of 50. يعني excellent when you are doing stomach and breast cancer. Okay, type of mutation of the gene not asked before, or I wrote germline mutations. Okay, in stomach asked me, give me one reason to raise the liver enzyme in this patient. I think in scenario patient has fatty liver. In this station of gastric carcinoma, written in the steps that patient has fatty liver. So we will ask you why patient has raised liver enzymes. You will tell because of fatty liver. Okay. The new question about gastric carcinoma, what others than adenocarcinoma can be happened with CDH1 gene? You will tell lymphoma, sarcoma, and breast cancer. If CD, who will be screening, when do screening, when to screen the patient, this is histopathology. Yes, you will find histopathology of cancer, of gastric cancer, not clear margin, 14 to 19 lymph node. What you will tell family, poor prognosis. This will be discussed, inshallah. This will be discussed. I think all the questions is around the CDH1 gene. These are the new questions. What is the function of the gene? Who will do the screening? And what is associated cancers can be? You will tell breast cancer and the colorectal carcinoma also can be associated with CDH1 gene plus lymphoma and sarcoma. تمام كده؟ طيب. We will go further for other questions about jaundice. I think the questions you discussed already and you solved them. خلينا بس نكمل gastric carcinoma. Okay. Gastric carcinoma updates from Bahrain and Dubai exam. The STEM states that the patient has gastric carcinoma, splenectomy, and elevated liver enzymes and fatty liver. What are the risk factors that cause cancer in this patient? Alcohol and smoking. If you have mutation in your CDH1 gene, what types of cancer may be associated? You have many lobar carcinoma, breast cancer, colon cancer, lobar breast carcinoma, and diffuse gastric carcinoma, and other. What causes of malignant ascites? Look to the picture. I will share it, the picture for malignant ascites. I didn't share it. General aspect of treatment of malignant ascites, drainage, venous shunting, and cell-free and concentrated ascites. يعني management will be in details. I will share. Why liver enzymes are high? Because of fatty liver. What could be the cause of confusion? Encephalopathy or patient went for hyponatremia. Others according to gastric carcinoma. Clear?
Clear.
I think all the questions here asked in this station already written. Okay. Significant of IHC, immunohistochemistry, tissue diagnosis, and diagnosis. Polycystic kidney disease. Polycystic kidney disease. Let me finish the episode. Updated question of polycystic kidney disease. I think here I didn't discuss yesterday. Okay, pathology of polycystic kidney disease. The examiner asked me new question. He asked me after 60 days from transplant, the patient complained of pain and swelling with deterioration renal function. So answer would be graft rejection. He accepted. Then asked me about cellular type of graft rejection with mechanisms. So and he said for you, this is clinical, not cellular. He is asking what is the cellular type of graft failure. Next question was what is the immunological reaction behind that rejection? Okay, you will say antibody and complementary reason, accepted this. Then we'll shift to the question post-transplant lymphoproliferative like yesterday. So the question of polycystic kidney disease correlated Basuni, cellular types of rejection. And it will ask you the cause of this rejection. You will tell natural killer cells and B cells. What's the immunological reaction behind that? Antibody-mediated cellular features of this rejection, early lesions like reactive lymphoplasmacytic hyperplasia, infectious mononucleus-like lesions, polymorphic BDTLD, and monomorphic also classical Hodgkin. This is lymphoma. This is about lymphoproliferative disorders. I think this what you will find. What is the cellular types of this early lesion like this way? What HALA stand for and its significance? Hemoleucocytic antigen, and you have HALA A, B, DR. The most important is DR. On examining the pathology slide, there is immunoblastic plasma cell diagnosis as we discussed yesterday. So keep this paper very important. Share the paper soon. معلش يا شباب. يعني I forget it. I remember it. Yes. So you have very important updates. Number one, polycystic kidney disease, like discussed exactly with Suzanne, except this paper or these 5 questions. You should keep them. Add them. Regarding of the guest, I think like we discussed now with differential Robin, everything we discussed with Maria, but they asked about CDH1 only. هو الوسيل بتاعنا ماله الوسيل بتاعنا ماله يا ابني؟ طب انا هقول له والله لا اوكي اوكي I think the station was gastric carcinoma. نظبطها في الممكن اللي جاي بعد كده الجاستريك كارسينوما مع الجست كلهم مع بعض.
I will add them together next time.
So gastric carcinoma tomorrow will be discussed plus the new questions we added today. The updates from Bahrain and Dubai. These questions about CDH1. وسام دخل اللجنه دي على فكره. وسام دخل اللجنه دي. He told me Dr. Salah all the updates you shared for us from Bahrain and Dubai exactly like you answered. I did. Exam was satisfied completely. ماشي. لو بريك الناس خلصت منك يلا. احنا كده لازم بريك بعد اللجنه دي.
ما نعملش لجنه كمان؟ طيب ماشي.
لا لازم بريك بعد اللجنه دي.
ماشي حاضر تمام.
10 minutes break then we'll be back.
Okay.
Hello, can I start now?
Okay, Dr. Mansour and Dr. Widad, you're with me, sir?
Yes, inshallah. Assalamu alaikum.
Alaikum assalam. Okay, so the Stanford station is a 44-year-old male patient seen in the clinic with a history of mild asthma and parathyroid surgery history. He has intermittent abdominal discomfort and pancreatic disease is being considered. First question for Dr. Widad, then Dr. Mansour, and go on. Okay?
Okay.
Okay, the first question is, can you please define parathyroid hyperplasia?
It is non-malignant pathology with proliferation of the parathyroid cells, an enlargement of the cell, number of cells, and enlargement of the size of the cell.
Okay. Next question, how many parathyroid glands are usually affected? Dr.
4
Mansour?
glands.
Okay. Dr. Mansour?
Yes.
What's the microscopic picture of the parathyroid hyperplasia?
It's increased the number of abundant sheaf cells, and this is one type, and there is another type. Increase the number of clear type of the cells, and with separated nests of oxyphil cells with fibrous stroma.
Okay. Next question, can you define the 2 top reasons for parathyroid hyperplasia?
Renal failure and Minn syndrome.
Okay, next question. The patient collapsed in the clinic, Dr. Mansour. The patient collapsed in the clinic. His glucose level cannot be recorded immediately. Later, it was confirmed to be 1.2 millimole per liter by blood sample. History showed repeated attacks of sweating and fainting. Which pancreatic neoplastic process may cause this clinical picture?
Insulinoma. Pancreatic insulinoma.
Okay, next question. Which part of the pancreas is usually affected?
Beta cells of Langerhans.
Okay. Next question, Dr. Widad. How insulinoma is confirmed biochemically?
By presence of circulating high levels of insulin at the same times of hypoglycemia, and by high circulating level of insulin, high ratio of insulin to glucose ratio, and presence of proinsulin and C-peptide.
Apart from insulinoma, what other pathology can be related to this condition?
Me or Dr. Widad? Is liver disease, abnormal insulin resistance, hereditary glucogenosis, and ectopic insulin production from some tumor like fibrosarcoma.
Okay, insulin-like growth factors from non-pancreatic tumors. This is the exact answer in the checklist. Okay, next question. What's the definition of men?
Men is a group of related conditions that inherited as autosomal dominant, characterized by hyperplasia or neoplasia of endocrine organs.
Okay, what other pathology would you suspect in this patient, Dr. Mansour?
Pituitary adenoma.
Okay. Next question, also the question for you, Dr. Mansour. What are the gene mutation that happens in insulinoma?
There is many genes for men syndrome, and also there is the mTOR gene for X matching for insulinoma, and there is the alpha thalassemia mental retardation gene DAX, TARAX and DAX.
Okay, next question. What is the two-hit hypothesis, Dr. Abided?
This is in the loss of function of mutation gene of in tumor suppressor genes. It is autosomal recessive. So for the cells to be carcinous, both of the cells tumor should be mutated.
Okay, next question, Dr. Mansour. What's the telomere?
Telomere is a repeated nucleotide in the repeated nucleotide sequence in the end of the chromosome that prevent the chromosome from fusion with other ones.
Okay. Next question, what are the genes responsible for cancer in general?
Tumor suppressor genes, mutation of proton oncogenes, and microRNA genes and mutatory genes.
Okay. This is the last question.
What is the mutatory
Great
gene?
job.
What is the mutatory genes?
It is
Example for them.
Like I think like BRCA gene.
BRCA 1 and 2.
Yes. This station came in Cairo on March also. كانت شيري امتى يا ماريا؟ في مارش
مارش
ولا في اوجست؟
لا اعتقد مارس.
لا كانت اوجست.
مش فاكر.
No, she was in March. Yes. This station came in March. The only question for this station, by the way, Dr. Maria discussed from the Rayleigh checklist. يعني all the answers from the Rayleigh checklist. So this one station in the Rayleigh checklist. The only question here, what is the genes in general? They told many genes. He wants the categories. He asked specific. I want the 4 categories. So I searched. I found the 4 classes. يعني this question many they stuck in this question. So I hope if this station will come, it will be accepted answer about the 4 classes of genes, proton genes, tumor suppressor genes, microRNA, and mutator genes like BRCA1 and BRCA2. I hope will be accepted inshallah. Other questions exactly like our mock. يلا next.
Okay, next we have Dr. Priyanka and Dr. Nazim or Nusrat.
Yeah, hello, doctor.
Hello, how are you guys?
I'm fine. What about you?
We're good. I'm good, thank you. Okay, so we will start with your station. First question for Dr. Nusrat and the next question for Dr. Priyanka, okay?
Okay.
A young female with a thyroid nodule and elevated calcitonin level. Okay. What is the single best investigation you would like to do?
FNSC.
Okay. Next question. What is the type of cancer that you would suspect and why if the pathology report returned as following? malignant cell features, amyloid deposition, immunohistochemistry stain positive for calcitonin, and stain for negative for thyroxine. What is the type of cancer you would suspect?
Is it for
Dr.
me?
Priyanka?
Okay.
Dr. Priyanka. Okay, Dr. Nashrat, you can go ahead.
It is medullary thyroid cancer because it's negative for thyroxine, positive for calcitonin with amyloid deposition.
Okay. Next question. What is the source of this type of cancer?
Parafollicular C cells.
Okay. Next question. What is immunohistochemistry in simple words?
It is a method of localizing specific antigens in tissues or cells based on antigen antibody recognition.
Perfect. How does it work?
The antibodies are usually linked to an enzyme or fluorescent dye. So when the antibody binds to the antigen in the tissues, the enzymes or the fluorescent dye is activated and the antigen then can be seen under the microscope.
What's the type of antigen antibody reaction?
Complement fixation.
TNM classification for thyroid cancer in simple words.
T1 tumor size is less than equal to 2 centimeter confined within the thyroid gland. T2 tumor size more than 2 to less than 5 centimeter confined within the thyroid gland. T3 tumor size is more than 5 centimeter confined within the thyroid gland. And T4 any tumor size which is outside the thyroid gland.
Okay. Actually, in the exam, he will give you like a size for the tumor and will tell you that there is a regional lymph node and there is no metastasis, and he will ask you what would be the TNM for this case. He's not going to ask you to just say how the whole table. Okay. If the patient developed hypertension, what would you suspect that she might have?
Pheochromocytoma.
Okay. What are the other adrenal gland swelling that you know?
Could be due to infection, abscess, due to trauma, hematoma, malignant neuroblastoma, and lymphangioma.
Okay. How can you diagnose pheochromocytoma?
In the plasma, free metanephrine, catecholamine stimulation test. In the urine, fractionated metanephrine, total metanephrine, vinyl mandelic acid. In the imaging, ultrasound, CT, MRI, MIBG scintigraphy, and PET CT.
Okay, if the condition is familial, what other pathology would you suspect?
Parathyroid hyperplasia.
Okay, what are the types of men?
Men 1, men 2A, and 2B.
What is the treatment plan for medullary thyroid cancer?
First, I will discuss with the multidisciplinary team, and after taking a detailed history and examination, I will go for total thyroidectomy with block neck dissection.
Do you know the types of neck dissection?
Yes, it is a radical, modified radical, and selective.
Okay, do you know what we spare in modified radical?
In modified radical, we spare the internal jugular vein, the sternocleidomastoid muscle, and the spinal accessory nerve.
Sure. I think this is the last question. Great job. Thank you very much.
Thank you.
Dr. Sah, do you have any extra questions?
لما هي كانت معايا في بارت ايه she is doing great at part A also.
It's
يعني
amazing.
amazing. She's doing great by the way in the exam. She went in the exam. طيب. This was my station in البحرين, and exactly like we discussed now, not came for long time. So no updates for this station except what we discussed now. تمام يلا next.
Okay, next we have Dr. Kabil and Dr. Ahmed.
Don't forget, I shared for you the role of immunohistochemistry. I shared for you the role of immunohistochemistry. Okay, so this question asked, so any station, they will ask you about the mechanism of it, what is the definition of immunohistochemistry, and what is the mechanism of action, and what its significance. Very important to tell this for tissue diagnosis and also for cytology.
Okay, so we will start with Dr. Ahmed, then the second question will be for Dr. Priyanka and go on, okay?
Okay, doctor.
Okay, doctor.
The stem for this patient is a young lady who came back from a foreign travel from Bangladesh with a cervical lymphadenopathy, loss of weight, and night sweats. First question for Dr. Ahmed, what is your two main differential diagnoses?
Cervical lymphadenopathy, loss of weight, TB, or Hodgkin lymphoma.
Okay, next question, which lymphoma would you suspect? He already answered. Okay, next question also for you. Which lab will you send her sputum to?
I will send for cytology and microbiology.
Okay, next question, what two rapid tests you would like to do for TB?
Recombinase polymerase amplification.
Hmm?
Recombinase polymerase amplification.
Yes, and the other test?
And uramine stain.
Uramine stain is not a fast test.
Montauk.
I don't know.
What else? PCR and quantiferon acid.
But PCR take 24 hours. It would be counted in rapid.
24 hours is rapid test.
Okay.
Okay. What will you put the specimen in?
I will put in the category 3 labeled biohazard bag, which is of color red.
Okay, next question. What is the organism of TB?
Mycobacterium tuberculosis.
Dr. Ahmed, this is turn. Okay. Dr. Ahmed, the question for you as well. What mycobacteria is found in immunocompromised patients?
Mycobacterium avium intracellular.
Dr. Ahmed.
Oh, sorry.
Okay. You can go.
Mycobacterium avium intercellular.
Okay. Next question, Dr. Priyanka. How long does it take to culture?
6 to 12 weeks.
Okay, perfect. Next question. You are given a fine needle aspiration cytology result showing necrotic tissue, histiocytes, and giant cells. Dr. Ahmed, what's your diagnosis?
Tuberculosis.
Okay. Next question also, Dr. Ahmed. What type of protein deposition is seen in TB?
It's amyloid AA.
Okay. Dr. Priyanka, what is giant cell?
These are actually multinucleated cells comprising of macrophages, often forming the granuloma and histiocytes. Examples are Langerhans giant cells and Reed-Sternberg giant cells.
Okay. Next question, surgically relevant examples for granuloma?
TB, leprosy, schistosomiasis, sarcoidosis, Crohn's disease, RA, and fungal infection.
Okay. If this lady is diagnosed with TB, what is your next step, Dr. Ahmed?
I will notify the consultant of communicable disease. I will give the patient antituberculous medication. I will ask her to avoid working in food factories, and I will perform a contact tracing. Last people contact with the patient for 21 days.
Okay, great. This is the last question I have. Thank you for both of you.
Thank you, Doc.
Dr. Salah, do you have any comments or extra questions?
No, Dr. Maria, so you're doing great. By the way, this station already present in posting all the answers from the real checklist. This station came recently also last year and exactly without any added feature. It's going the same like this way. Okay.
Okay, thank you guys very much. Next, we have Dr. A and Dr. Muhammad. There is a lot of Dr. Muhammad, so I don't know which one. So can you please raise your hand?
Hello, Dr. Maria.
Hello, Dr. A, how are you?
I'm fine. How are you?
Dr. Muhammad, who chose the station, can you please raise your hand?
ساعتها حتى ممكن يغير اسمه محمد عشان يدخل. عمال يشحت من بدري. دخليه.
ما هو I don't want to miss the schedule. Dr. Said already is in the spare list, so he will automatically take a station in the next session.
لا اسمك يا سعيد، سمي نفسك محمد وفي عيدك. خليك مفتح كده.
Okay, so I cannot find Dr. Muhammad, so I will give a chance for Dr. Muhammad Fadl because his mic was not working on his station.
تمام ماشي.
Hello.
Hello, how are you?
Hi.
Okay.
Dr. Salah, how are you?
All right, so the sum for this station is a male patient who is a heavy smoker and alcoholic with dysphagia. He has history of GERD and weight loss in a short time.
This station came when يا دكتور ماريا؟
When?
آخر مرة جت امتى طرافيش؟ احنا بنتكلم الناس انا وانت على طول. جت بقى لها فترة ما بتجيش صح؟
بقالها فترة طويلة شوية يعني السنة اللي فاتت تقريبا ما جاتش.
لا. يعني this station for the first time and last time. Dubai and Hyderabad exam. Dubai and Hyderabad exam. Came at the same time with AV fistula for the first time. Cancer was and AV fistula was new in Hyderabad. So regarding pathology, any station can come. يعني they have no concept about. يعني some asked me, so which stations are more commonly to be repeated? History and pathology, any station can come, especially all the stations.
Okay, Dr. Aya, what is the normal lining of the esophagus?
Non-keratinized stratified squamous epithelium.
Next question, what is the most probable diagnosis, Dr. Muhammad?
Esophageal cancer.
Okay, next, what are the etiological factors of cancer esophagus in this patient in particular?
GERD and smoker.
Okay, what is the effect of prolonged GERD?
It would lead to chronic irritation of the lower part of the esophagus. This would lead to metaplasia. That's what we call Barrett esophagus. The squamous epithelial will be changed to the low columnar epithelium with goblet cell.
Okay, next question, what is the effect of, which test you would like to do for this patient?
Endoscopic ultrasound and biopsy.
Okay, next question, what the cells obtained will tell you?
It will tell you the type of the malignancy that is present in the esophagus.
What else?
It's also the stage of the tumor. T-staging.
Staging?
It is most likely grading of the tumor rather than staging.
Yes, grading of the tumor and immunohistochemistry telling you the type. Okay. Next question, what is the stain used in immunohistochemistry?
Cytokeratin.
Next question, what are the treatment options for esophageal cancer?
It depends whether the tumor is resectable or not resectable. If the tumor is resectable, we're gonna do a esophageectomy with the gastric conduit, and then radiotherapy or chemotherapy. If the tumor is not resectable, we're gonna do chemotherapy and feeding genostomy or stenting, or we're gonna do brachytherapy to the esophageal cancer.
Okay. Next question. If the patient developed pleural effusion, what's the possible cause?
Extension to pleura, obstruction of thoracic duct, or lung metastasis.
Next question. What pathological tests you would like to do?
Pleurocentesis and central for cytology.
Yes, fusion cytology. How are you going to treat?
Thoracocentesis, pleurodesis, indwelling catheter, or pleuroperitoneal shunt.
Perfect. The patient developed enlarged supraclavicular lymph node. What will you do?
For needle aspiration cytology or excisional biopsy.
Excisional biopsy. Okay. Investigation for MI.
ECG, cardiac enzyme troponin, and CKMP.
Okay. What is troponin?
It is a complex protein that is located in the muscle of the heart.
Where is it found?
In the myocardium.
Where else?
Where else? In the skeletal muscle also.
Yes. Okay, that's the last question I have. Thank you. Thank you guys very much.
Thank you.
Okay, we will move on to the next station, Dr. Rami and Dr. Fatima. Dr. Rami. He's not here. Dr. Fatima. Okay, Dr. Yasmin.
Sorry, Maria. For previous station about management of pleural effusion, please take care because in examination, the station of test examination is COPD. Recently in UK, they brought malignant pleural effusion. So management of malignant pleural effusion will be from here. Will be exactly from here. تمام؟ محمد انت شغال فين يا محمد؟
هلو.
انت شغال في معهد اورام؟ شغال في الاورام مش كده؟
في الاورام يا باشا.
تعرف حسام؟
حسام صاحبي.
عبد العزيز؟
عبد العزيز كمان السينيور بتاعنا.
السينيور بتاعك صح؟
السينيور بتاعنا.
By the way, Muhammad, the highest score in April 2021 exam was the highest college. أعلى سكور في الكلية الملكية يا شباب. After him حسام الصلاحي the highest score also in the college. اليمنيين دوت ما طلعوش سهلين. ماريا the highest score في الكلية الملكية.
الله ينور.
عبد العزيز بعت رسالة ايه؟ شفت الجونيور بتوعي؟ قلت له انت ما كنت زيهم ليه بقى؟ انت ما جبتش الاول زيهم ليه؟ ربنا يوفقك ان شاء الله.
حبيبي.
يا رب ان شاء الله. Okay, Dr. Saeed for this station.
السلام عليكم.
عليكم السلام. Okay, anyone else? Dr. Yasmin from the spare list. Dr. Isra, Dr. Abdulrahman, anyone in the spare list?
باشا مش دي الستيشن اللي كانت جت لنا اول مره في لندن؟
بتاعتك يا باشا، ادخل لي بقى.
دي امتحنتها انا.
ايوه دي بتاعتك، دي لجنتك. وشوف كده معايا، انا عايز اساعد فيها.
نفس الكلام بالظبط.
طيب تمام.
كان نفسه، وحتى الراجل استغرب ان هو الكلام كان معمول كده.
اوكي دكتور منصور. Okay, we will start with you, Dr. Saeed, then Dr. Mansour, and go on. تمام؟
Okay.
A 70-year-old man did colonoscopy that showed some rectal tumor. A biopsy was taken and it showed adenocarcinoma. Okay. The first question is, what are the features that should suggest poor prognosis?
First, poor differentiation due to grading, advanced stage, signet cell carcinoma type, high carcinoembryonic antigen, or spreading to surrounding with obstruction and ulceration.
Perfect. Next question, Dr. Mansour, what's the difference between staging and grading?
In general, the staging is most likely clinical and grading is most likely histological. Staging that explaining the spreading and depth, spreading and prognosis of the cancer, but grading is explaining the behavior of the cells itself, if differentiated or undifferentiated.
Next question, if the patient had a concomitant cancer at the anal rectum, which likely would be the type?
Most commonly, squamous cell carcinoma.
Okay. Resection was done and only one of 19 lymph nodes were involved. What is the end status?
N1.
Okay. A few months later, the patient developed hepatic metastasis with ascites. Okay, ascitic tab show atypical cells. What pathological test would you like to prove the origin, to prove the origin?
Yes, tumor marker like carcinoembryonic antigen with use immunohistochemistry.
Okay. Also, the question for you: what's the difference between immunohistochemistry and tumor marker?
Immunohistochemistry. Excuse me.
I don't.
Dr.
For
Said,
me, the
yes,
question.
the question for no, for Dr. Said.
Yes, sorry.
Okay, immunohistochemistry is a technique used to by using complement fixation technique and antigen antibody reaction to search for a protein used by cancer and using antibody to make certain protein that visible by specific dye. Tumor marker, they are some proteins help for us for follow up some types of tumors and differentiate between each others and follow up the grade and the degree and the effect of treatment and the behavior of the tumor itself.
Okay, Tamim. So the immunochemistry is a technique that we use to identify a certain antigen or a protein using an antibody mechanism and seeing it under the microscope, while the tumor marker is a protein produced by the body in response for the cancer or by the cancer cells itself.
Yes.
This is the definition of the tumor marker. Okay.
Okay.
Next question, what's immunohistochemistry in simple words?
This is a method to localize a specific antigen in a cell or a tissue based on the technique of complement fixation or antibody antigen recognition by specific dot.
Okay, Dr. Mansour, the type of antigen antibody reaction in immunohistochemistry?
I don't recall this question.
The type of the
complement fixation, you mean?
Yes. Okay, next question, also Dr. Mansour. How immunohistochemistry will help you make a decision in chemotherapy?
Because it depends on the result of immunohistochemistry, we can decide the plan of management, like in the breast cancer. We can specify if there is hormonal receptor or no to start hormonal therapy.
Okay, how tyrosine kinase inhibitor works, Dr. Said?
Yes, tyrosine kinase, it is a type of monoclonal antibody that so when using tyrosine kinase inhibitors that block these receptors, and by inhibition this prevents signals that produced by this tyrosine kinase which cause cellular differentiation and growth and division.
Okay, next question. 6 months later, the patient developed a large pelvic tumor. Is this patient at high risk of developing venous thromboembolism?
Yes, of course, she is in high risk because she is in a hypercoagulable state because the tumor or also the big pelvic tumor is making stasis.
Okay. How are you going to diagnose pulmonary embolism?
By D-dimer, by CTPA. Sometimes we have to do Doppler ultrasound for calf veins. Also chest X-ray. Chest X-ray.
Chest X-ray. Yes. What's the complications of pulmonary embolism?
Pulmonary hypertension, congestive heart failure, I think.
High risk of mortality if not treated.
It is acute and this is affect large vessel.
Yes.
Yeah, pulmonary hypertension.
لا. If affecting large vessel or acute, it will cause death if left untreated.
Okay.
Okay. What's the content of blood thrombus or how it is formed?
Me or who?
Yes, Dr. Said.
It contain platelets with fibrin mesh and some type of cells, which is called I don't remember this.
Aggregated platelets and red blood cells that form a plug and a mesh of cross-linked fibrin protein. That's it.
But there is a type of cells that I don't remember.
This is the answer I have. Which
Okay.
type of cells?
Okay.
Okay. How to obtain plasma from blood?
By centrifuge.
Separation by centrifugation, centrifuge.
Yes.
But by using clotting factors, clotting anti-clotting factor. As we
Yes,
didn't
you have
use
to
this.
add an anticoagulant first, and then you put it in the centrifugation for 15 minutes. Okay. I think this is the last question in this station. Yes.
بس في حته بس في الجزء بتاع اللي هو الثرومبوسيس اللي حصل كوزس اوف ثرومبوسيس ان ذيس بيشنت في البلفيك بتهيألي كمان كان في الانفيجن بتاع باي انفيجن باي تيومر اتسيلف انفيجن اوف بلاد فيزلز باي تيومر اتسيلف so the three corners of vercauter right is present in this case.
تمام. فقصدك يعني على الكويستشن اللي هو high risk for
and stasis.
Yes.
And then invasion of the blood vessel itself by the tumor.
هو دكتور منصور قال compression by the tumor. تمام بس هي فعلا compression أو invasion of the blood vessel itself. Okay, Dr. Sah, do you have any extra question? Dr. Said, do you remember any extra questions in this station?
You asked the question already. This was rectal cancer, came in UK. Is the question discussion by this way? Plus, I shared paper, very important paper for you about contents of the blood thrombus and how can be formed. Yani will tell about everything about the vercauter triad, everything about them, blood vessel injury, stasis, plus also coagulopathy because of malignant cells. You can tell
ماشي
that.
اسم السيلز ايه يا باشا؟ اسم السيلز كانت ديسموزد سيلز او ديسمويد سيلز حاجه كده.
كانت مكتوبه اسمها؟
لا حضرتك كان مكتوبه في ستيشن تانية بس انا مش فاكرها.
السيل بتاعت ايه؟
بتاع الثرومبس.
Admixed cells, I think.
ايوه admixed yes.
admixed اوكي عندك. طيب. contents of blood thrombus and how formed, how to obtain plasma from blood, difference between immunohistochemistry and tumor markers, how immunohistochemistry helps in decision of chemotherapy, how tyrosine kinase inhibitors working, and name one of them. Okay. Station exactly by this way. Exactly. I know it's a difficult station, but it will go smoothly, inshallah, if you will follow what we did in the mock. Plus, I shared all the answers discussed with Marina, I shared already in the group. Okay. Regarding of TNM classification, I think many of you with me in part A, you know, the question came in January 2021 about TNM classification for cancer colon and the TNM classification also for cancer breast. جابوها يا مريم في part A. That was أسئلة part
أنا فاكرة.
A. So we should keep them. يلا next.
Okay, next we have Dr. Sarah and Dr. Venus. Dr. Sarah. Dr. Venus طيب. Anyone? Okay, Dr. Hadir.
Hello.
Hello, Dr. Nidal, how are you?
Fine. How are you?
Okay, Dr. Hadi, sorry, Dr. Nidal and Dr. Nabila.
Yes.
How are you?
Yeah. I'm fine, thank you. How are you?
I'm good. So can we proceed with the station?
Yeah, sure.
Okay. We'll start first question with Dr. Nidal, then Dr. Nabila, and go on. Okay. A female patient who underwent mastectomy for breast tumor 5 years ago, as well as paroidectomy for pleomorphic adenoma 10 years ago. Now she presents with supraclavicular lymph node enlargement. Okay,
Yes.
Dr. Nidal, first question, what is the investigation you would like to do?
Fine needle aspiration, cytology, then excisional biopsy.
Mhm. Next question, what is the imaging you would like to do?
Me?
Yes. Dr. Nabila?
Me?
Okay.
Imaging.
Imaging I would like to do is, sorry, MRI.
MRI from the beginning?
Then ultrasonogram. Then
Sorry?
MRI, ultrasonogram. It's on the mastectomized site, right?
Yes.
So ultrasonogram and MRI.
And you will do mammogram for the opposite side, of course.
Yes, mammogram of the opposite side. Thank you.
What is the test to be done on the fine needle aspirate?
Immunohistochemistry, fish. Also, I want to do a receptor. Receptor status.
Next question. Which receptors?
It's ER, PR, and HER2 receptor.
Okay. Next question. Why is ER receptors important?
Important for blood of treatment, according to that. Also sensitive to treatment, hormonal therapy.
Okay. Next question. What is HER2?
It's an oncogene biomarker with a transmembrane human epidermal growth factor, receptor 2, and it's overexpressed in 50% cases of breast cancer, which indicates bad prognosis.
Okay. What is the difference between histology and cytology?
Histology study the cells itself. And, sorry, study cells itself, and histology study this is architecture of the tissue.
Okay, next question. When cytology is deemed to be inconclusive?
Cytology is deemed to be inconclusive. Or when there's inadequate sample, when
Yes.
Sorry, infection, hematoma, or trauma, then
Dr. Ndaldi, know the answer.
Yes, in poor fixation, insufficient cells. Also, if this stain have wrong stain, sorry, if there is any blood or inflammatory cells, also mislabeling this sample for sample.
Okay, the presence of blood and inflammatory cells that is masking the cancer self itself. Okay?
Yes.
You have to mention that it's masking them.
Okay.
Okay, so you are shown a fine needle aspiration cytology report showing a C4 lesion. What is the meaning of C1, 2, 3, 4, and 5?
it is a cytological report interpretation. C1 means there is not adequate tissue. C2 is sorry, C1 is benign. C1 is inadequate tissue. C2 is benign. C3 is equivocal. C4 is suspicious, and C5 is malignancy.
What is adenocarcinoma?
It is the cancer in the epithelial glandular button.
How pleomorphic adenoma can transform into adenocarcinoma?
How pleomorphic adenoma can transfer to adenocarcinoma? Pass. I forgot.
Dr. Nal, do you know the answer?
No, pass also, sorry.
How do tumor metastasize?
Okay, by tumor mets by release vascular endothelial growth factor that is lead to angiogenesis in lymph and also drainage in the sentile lymph node.
Okay.
Also
next question.
permeation and embolization.
Okay. They're usually looking for the VEGF. What
Sorry?
hormonal therapy to give in pre and postmenopausal patients?
In premenopausal, we give tamoxifen, the anti-estrogen, and in postmenopausal patients, we give anastrozole, that is aromatase inhibitor.
Okay. The patient has redness around the nipple. What do you think this might be?
This could be abscess, Baggett's disease, abscess, Baggett's disease, or hematoma due to trauma.
What's the main differential of the patches?
What's
eczema?
Eczema. Yes. So your main differentials would be patches, then eczema, then you can mention the abscess.
Sorry.
What is the pathophysiology of Paget's disease?
It is the extension of ductal carcinoma in situ up to the lactiferous duct and into the contiguous skin and of the nipple, producing unilateral crust exudate over the nipple and areolar skin.
Okay. Okay. This is the last question I have.
We have question, miss, and
yes,
we don't know what the answer.
I want Dr. Salah to just mention it. Dr. Salah, the question for the base gene, how was it exactly asked? Because I don't remember how the question was asked.
Okay. What's they missed? What's the question they missed?
The relation between the
Pleomorphic
pleomorphic adenoma and the transfer into the adenocarcinoma.
This function of the 53. جبتها منين دي يا سعيد؟
11 11
مش سامع.
اوكي وات ايلس؟ طيب it's base gene يعني we told BRCA gene by the way is sharing but examiner not accepting this answer but when they told the base gene examiner was very happy about base gene. What is base gene؟ ما قرأتوهاش انتوا قبل كده؟ اوكي base named breast cancer and salivary gland expression BASE. So breast cancer and salivary gland expression. Okay. So identification of breast cancer gene that encodes a secreted protein designed base breast cancer and salivary gland expression. This support is a common biology for these tumors together. Combination between parotid cancer and breast cancer. So the question here asked what is if you will go for the STEM again. I received today one question from Dr. Mansour. He told me they are not asking what is the pathophysiology of Paget disease. They asked what Paget cells. Before going for this question, mechanism of aromatase inhibitor. Asked also in this situation, aromatase inhibitor works by inhibition the action
of androgen
to convert this androgen into estrogen. Okay, by process called aromatization. I shared it already. This is mechanism of aromatase inhibitor. So another question asking what is definition of Paget cells? Yani some told me the question asked by this way. Anyhow, nobody sent for me this question, but we will share it. We will share it. I don't know yani, if any candidate told me, but they asked by the way about the pathophysiology of Paget disease. So if we'll ask you about the Paget cells, Dr. Mansour sent for me. He gave me answer, but I am not satisfied about his answer. He told Paget cells is large pale staining with round nuclei never invaded the basement membrane. By another definition, it is a malignant epithelial cells derived from ductal adenocarcinoma of the breast that invade into the skin of the nipple and the areola area only. Okay. I will share it. Other questions are the same.
Dr. Salah, can I ask something?
Yes.
So you're saying that the relation between breast cancer and the parotid adenoma are due to BRCA gene.
Overexpression of base gene.
Okay.
What is the base? As I told now, base. Sorry. I told what?
Base breast associated
breast cancer and salivary gland expression. Once in base gene, he will accept. Plus, if you ask you what else, tell him about BRCA. Tell him about BRCA. If we'll ask you what else, but don't start by BRCA.
Okay, so I got some. Got some studies that showing that only that as the adenoma, pleomorphic adenoma can occur both in breast and parotid gland. This is one similarity, and there are certain tumor-related protein receptors like HER2, EGFR, AR. These also causes tumor expression, and these also can also has biological similarities between these two lesions.
No, he's waiting the base gene.
Okay. Base gene. Thank you.
Sorry, Dr. Salah, is this answer for question 11? I don't have the answer.
Right. Which question?
11.
وفين يا مريم؟
Pleomorphic adenoma, how can it convert to adenocarcinoma?
You didn't answer this question, Maria?
لا ما هو we said that this question is not asked in this way.
Oh, okay.
This is not the proper way. This is how we got the question at the beginning, and then When we ask more, we know the proper way the question was asked, and the answer is, as Dr. Salah says, the base gene.
Okay, okay. Thank you.
Thank you. Okay, next we have Dr. Omar and Dr. Burpee. Dr. Omar. I think he's not here. Okay, anyone would go for the station? Okay, can anyone go for the station? Can raise their hand? Dr. Said?
Maria, you have in this station polymorphic adenoma and the breast, I think, asking about the 5 pathological steps by which carcinoma spread, how to differentiate carcinoma from lymphoma, eroding of the carotid artery, why bleeding not stopped. This will come later.
ده كان في
This
الموك
is
يا
in
باشا
the
أنا كنت
parotid.
سمعت. في الباروتيد مع البيس جين دي بتبقى في الباروتيد مش هنا.
دي في الباروتid مش هنا.
تمام كده تمام يلا.
Okay, Dr. Said, are you ready?
Yes.
Okay. A case of proximal femur fracture known to have hypothyroidism and history of mastectomy 5 years ago.
Okay.
Okay. You are going to be given a lab results that will show increase in the urea creatinine and hypercalcemia.
Okay.
Right? What are the possible causes for 2 possible causes for hypercalcemia?
As the first is caused by renal failure, okay, or renal impairment with obstruction. Second, bone metastasis if it is tumor.
Okay, next question, what to look for in bone scan?
I'll go for active reuptake by the cells and maybe high cells hotspot. What's thing? It's hotspot. Yes.
Next question, why you will do total hip replacement or hemiarthroplasty and not fixation with nails and screw?
As the patient is with low immunity, high risk of infection, high risk of non-union, and high risk of failure and after fixation.
Okay, why would you send the head of the femur to pathology?
For analysis to exclude any malignancy or metastasis, and if it presents malignancy, I'll go for grading and staging of the tumor.
Grading of the tumor, staging, LISM imaging. Okay.
Yes.
Staging is not done with pathology. What is the mechanism of action of radiotherapy?
It is acting by ionizing radiation with the destruction of hyperactive cells and by damaging the DNA of the cancerous, leading to cellular death of the cells.
Okay. تمام. Why to use radiotherapy other than killing the cancerous cells?
Yes, so using this as to shrink the cells as a palliative in case of non-operable cases, or using to pre-surgical removal if it is operable, to shrink the size and become lowering the size of the cancer to enable the removal of it or excision of it, and using after surgery to kill the remnant cells. So it is used in the 3 stage.
Okay. And also for management of pain in cases of prostatic cancer.
Yes.
Okay, 2 medications for breast cancer.
What? Excuse me? Two medication for breast
medications.
cancer? Yes. At premenopausal, tamoxifen, postmenopausal, anastrozole.
Okay. Herceptin mechanism of action and how it works.
Yes, and
or how it works.
Herceptin itself. Herceptin is antagonist for HER2 receptors, which is human human cellular growth factors, and this is present in 15% of the breast cancers. Okay. There is monoclonal antibodies interfere with these receptors, which is embedded in the cell membrane.
Exactly. Okay. Why aromatase inhibitor is not given in premenopausal women?
Not given in aromatase inhibitors. This is presence in postmenopausal. As premenopausal, there is still producer ovary that produce estrogen. So when it give it, I think it's not practical to use it.
Yes, it will not stop the ovaries from producing the
The
estrogen
estrogen
that will
presenting in the blood as it is, there is an origin for it, which is over.
Yes. Okay. That's the last question, I think. Thank you very much.
This one of the new stations came in UK in October, last October. It's going exactly by this way. It's going exactly by this way. All the updates and all the questions we shared for them. And as you know, lastly, we have one candidate there scored 97. So all the answers are almost correct. No update.
طب يا باشا سؤال، هو دي هايبوثايروديزم ولا دي مثلا فراجيلتي فراكشر ولا دي ايه بالظبط؟
الستيم like what they give for me. The stem exactly patient has hypothyroidism. جا كده يا مريم. Sorry, patient has hypothyroidism and the patient has fracture of the femur and she has history before 5 years for cancer breast mastectomy done for her.
ده هو واتس ذا رول اوف هايبوثايروديزم ان ذيس كيس؟ مفيش اي رول، لان مش يعني ما سالنيش على الثيرويد خالص.
كانوا في الستيم، كانوا في الستيم هايبوثايروديزم.
ماشي.
كانوا في الستيم. Last station يا مريم.
Oh, last station, I think. Okay, Dr. Abdulrahman. Hello.
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 Yes, Dr. Marie.
Okay. Okay. A patient known of having hypothyroidism presented with a hard swelling in the inguinal region, and the GB sent her for biopsy. Tamam. First question, if the inguinal lymph node turn out to be lymphoma, what are the distinct types of lymphoma?
Non-Hodgkin lymphoma.
I'm sorry?
Non-Hodgkin lymphoma.
What are the types of lymphoma?
Non-Hodgkin lymphoma and Hodgkin lymphoma.
Okay. How malignant cells survive in lymph nodes?
By release of exosome.
Release of what?
Exosome. Exosome.
Okay. What else?
I didn't remember.
We answered it like 3 or 4 times till now in the same mock.
Yeah, and mechanism of
it
spreading,
produces the VEGF that causes the angiogenesis.
I know that one. I know that one. But vascular lymph node, and I answered the first station also, but I think another one answered 10. So I will try. I will answer. Vascular primary tumor will produce vascular endothelial growth factor C and D, makes vascular lymph node expansion and lymphogenesis in the tumor and draining central lymph node. This will promote metastasis of the tumor.
It will promote the survival of the tumor. Why is melanoma pigmented?
Because will affect the melanocyte.
Because the cell of origin is the melanocyte,
Melanocyte.
which is pigmented. Okay. What mention 4 types of melanoma?
Acral, superficial, nodular, and superficial nodular, acral, and melanocytic.
Okay, so superficial spreading, as you said, lentigo maligna, acromelanoma, nodular melanoma, amelanotic melanoma. Okay. 3 methods of spread of lymph nodes.
Embolization, permeation, and mechanism of produce endothelial vascular endothelial growth factor C and D that
Yeah.
promotes metastasis. Yeah, I mentioned before.
A lesion under the toenail was found, and a decision to amputate the toenail was taken with excision of the lymph node. What is the objective behind this decision?
I think to excise margins and depths according to the Bercellus and Clark's criteria.
You are going to amputate the whole finger and do excision of the lymph node. Why?
To check metastasis.
To prevent metastasis. Okay, what else?
Because I don't know more than
Prevent local spread, control the pain, control the what else? Invasion. Okay. Proper safety margin. Okay. And also, yes, the loss of function itself. What is epithelioid melanoma?
Epithelioid melanoma. Bus.
Epithelioid melanoma is the cells that resemble the epithelium because it has abundant eosinophilic cytoplasm, enlarged and oval-shaped nucleus. What is satellite lesion?
Bus.
Okay, satellite lesion is a focus or area of melanoma separate from the main tumor mass as a result of lymphatic spread and growth tumor and embolus locally. What is the gene mutation in familial malignant melanoma?
Familial malignant melanoma. I don't know.
BRAF gene.
BRAF gene. Oh, sorry.
Post-operative, the wound is red and swollen. Culture revealed diplococci. Can you give examples for that?
Streptococci and meningococcal. Meningococcal, streptococci, and
you can divide it into gram negative and gram positive.
Okay, gram-positive streptococci and staphylococcal, gram-negative meningococcal and
Yes. Neisseria, Actinobacter, Haemophilus, Brucella.
Brucella.
Next, the patient become toxic with the rapid spread of infection. What do you think happened?
Necrotizing fasciitis.
Yes, necrotizing fasciitis. Okay, this is the last question I have.
Go back, Maria. Go back. I remember malignant melanoma meds came by this way in Khartoum exam. Nizar, my friend Abu Ahmed Nizar, he sent for me this station. It came before my exam, by the way. It came by this way. Then this station repeated again, and I shared in the notes group. Melanoma station stem patient with renal lymph node enlargement also has hypothyroidism. Two types of lymphoma, how many cells survive in lymph nodes as our POC. Okay, gene mutation is brave gene. Why is pigmented? Because coming from a site which have melanin. The lymphoma method of lymph nodes, as we discussed before about the methods of spread of lymph node, or the 5 major steps for METs. Melanoma, what is the importance of surgery? Why would remove melanoma? I shared a very important picture for it about amputation. Why will do amputation? Because of significant pain. So this can control by this way. Pain can control by medication. So we'll go for amputation. The original tumor has spread extensively. So better to remove it because of METs and loss of function. Plus the cancer has come back after 1 or more previous surgeries. If you will do more than previous surgeries and came back or recurrent, you can remove it also. This is the answer, by the way, accepted by this way. I shared also radiation units by very nice way. I shared the causes of ascites, which I asked before. They like this station in UK centers and also in Khartoum. They like this station, by the way. But nowadays no exam in Khartoum. يلا. Last station.
We can skip this station, Dr. Saleh, ونخليها بكرة because tomorrow they have only 10 stations remaining. So.
يعني هتكلموا مراد عليها ومين اللي داخل بكره؟
Yeah, Dr. Murad. I will send it to him and he can just
بكره كان
him as in the book.
How many station was مراد tomorrow؟
Just 10.
خلاص ماشي خلاص بكره. انا عارف انك تعبتي ودلوقتي اتس
3 خلاص مش قادرة.
I think that's enough. كده خلصنا يا شباب النهارده. All the station in the book. All this station in the book in the drive. Updated the station like this way. Okay. ماشي يا شباب. بكره هشوف مع مراد الساعة كام إن شاء الله. شكرا يا دكتورة دي.
Thank you everyone. You all did a great job.
We will do all pathology station, even the updated station. We will do all. So tomorrow we'll finish from pathology إن شاء الله. يلا مع السلامة.